Hello, everybody. My name is John Priest. I am a ECMO specialist at Boston Children's Hospital. Today, we're going to be covering lung rest and recruitment strategies during neonatal and pediatric extracorporeal life support. If you will, you could either scan this QR code or go to www.menti.com and enter this this code, and I'll just wait a couple minutes for you to do that. Maybe just actually 1 minute. Just give me a thumbs up when you get in there, so I know people are logged in. All right. So to help with time, I'm good with 7, so we'll go ahead. Again, these each question will be on the subsequent slides. But as far as disclosures, I have none. Most of this presentation is going to be regards to VA ECMO, but we will get in. I will make some comments about mechanical ventilation strategies during VA ECMO as well. As far as objectives, again, we're going to be talking about mechanisms of lung injury. We're going to talk about lung rest modalities and strategies, lung recruitment strategies, and go over a little bit what's out there in the literature, although that is constantly evolving. So first question, what's your specialty? Are you a physician, a perfusionist, a nurse, a respiratory therapist, or something else? All right, so mechanical ventilation, why do we need it? So there's limited data in neonatal and pediatrics. There's a very large center-to-center variation in what strategies you use. Lacking expert consensus and evidence practice is huge, and optimal settings are very debatable. As far as optimal tidal volume, optimal PEEP, and optimal lung recruitment. And this X-ray here that you see, this is typical of what we see with neonatal and pediatric ECMO. A lot of these patients getting minimal tidal volumes when they go on ECMO. They're very acidotic. Their PO2 is very low, very hypoxemic. And then when they go on ECMO, there's usually an inflammatory response where the tidal volumes get even lower, and oftentimes you see a complete pacification or a complete whiteout of the lung fields. So in this situation, it's very important to determine what you're going to use for rest settings, because this could really affect the back end of ECMO when you're starting to wean and starting to come off ECMO, and can really determine the extent of lung injury that what your choices provide. So what are the goals of mechanical ventilation during ECMO? Just to think of one thing to reduce this to the least, the most easiest to understand. So basically, to allow the lungs to recover at a normal pace or a natural pace without excessive pressure or volume applied to the lung, especially to the more vulnerable areas which are highly susceptible to hydrogate lung injury. And what I mean by the more vulnerable areas is there's always going to be a portion of the lung that's exchanging gas. You want to make sure you protect that, because again, like I said, you're going to need that on the back end of ECMO when you're weaning. You don't want to cause any more additional lung injury. And as far as VA versus VV strategies, it's a little bit different. As you know, ECMO is not complete cardiopulmonary bypass. And if we talk about VV ECMO, it's even less of a bypass, because anything that goes through our external membrane oxygenator still has to pass through the lungs. So again, this is going to all mix with the deoxygenated or hypercarbic blood coming through the lungs. So it's an even more strategy in VV ECMO to not de-recruit what you currently have in respect to high inspiratory pressure or high peak expiratory pressure, to maintain a safe range, to make sure you don't add to the current lung injury that's already occurred. So what are the mechanical ventilation strategies? So limiting tidal volume, that's going to avoid your volume trauma. Reducing alveolar pressure, so your peak inspiratory pressure or perhaps your peak expiratory pressure, that's going to avoid your barotrauma. And minimizing cyclic collapse and reopening of the alveoli, that's avoiding atelectatic trauma. And this is again common in ECMO, because there's always areas of the lung that are open, that do participate in gas exchange, and you don't want to hurt them. Timing of recruitment is very important. You wait too long to recruit the lung, you're going to spend more time on ECMO. You go too early, you're going to cause more lung injury. Optimal oxygenation. We all know that with these neonatal patients, we want to avoid high concentrations of FiO2. So again, what's the right percentage of inspired oxygen? And decreasing mechanical power, which we'll get into in a minute, which is an interesting calculation. So this mechanical power, the basic terminology is energy spent per breath multiplied by your respiratory rate. This increases exponentially with increases in tidal volume, driving pressure, flow, respiratory rate, and PEEP. And these are all things that we can manipulate with a bedside ventilator. Independent risk factor for ICU mortality and ventilator-free days and duration of ICU and hospital stay. So this is the very complicated equation here, but if you break it down to simplest terms, respiratory rate, we control that directly. Tidal volume, again, we can control that directly, whether you're in pressure control or volume control. And then you got PEEP and delta P. Again, PEEP, we can control that directly. Delta P, whether you're in volume control or pressure control, we can control that. So all these things go into controlling mechanical power, and in the end, in hopefully decreasing your ICU mortality and ventilator-free days. But it does come at a cost. If you wean too quickly, you may de-recruit the lung, again causing more lung injury. Or if you maintain high ventilator settings for too long or too extended period of time, you're also going to add to the ICU mortality or ventilator-free days. So it's definitely a strategy that you should all think about. So getting into the first study, this is one of my favorite studies or favorite papers to read. Near apneic ventilation decreases lung injury and fibroproliferation in acute respiratory distress syndrome model of ECMO. This was published back in 2019. So what these authors did, they used domestic pigs, about 28 kilos, and how they prepared these pigs. They ventilated them 10 per kilo with a mid-teens respiratory rate, a PEEP of 5, and 100% FiO2. How they induce lung injury is they use repeated 30 per kilo lung lavages of 0.9% saline until they get a PF ratio of 250. They followed this up with 2 hours of injurious ventilation, which was 40/0 and a rate of 10 with an IDE of 1:1. Then return them back to baseline before they initiated ECMO. And they classified these groups into a sham or non-productive, which they kept at the 10 per kilo and the PEEP of 5. They did a conventional protective group, which is a volume control ventilation of 6 per kilo, a PEEP of 10, a rate of 20. And then they use what they called near apneic ventilation, which is the pressure control of 20 over PEEP of 10 and a rate of 5. So just getting into terminology as we go through this presentation, I'm a respiratory therapist, so this comes natural to me, but if you're not, a pressure control of 20 over a PEEP of 10 is what we call a delta P of 10. So it's 10 plus a PEEP of 10, which gives you that pressure control of 20. And just to quickly summarize this, there was large difference in two determinants of lung injury: mechanical power and driving pressure. Driving pressure is that delta P, and mechanical power is that earlier calculation of peak inspiratory pressure, PEEP, respiratory rate and flow. Renal and liver dysfunction in the non-protective group was non-significant. Near apneic group had the least alveolar disruption, neutrophil infiltration, hemorrhage, and lung injury score. Limitations of the study. The FiO2 was set at 100% throughout the study. And again, what's really important is this is a 24-hour study, and similar to ECMO data or ELSO data, you get 24-hour data with that group as well. In my mind, the 24-hour data is not all that important. What I'd really like to see, and what's not possible with an animal study, is to see 2-week, 4-week, the 1 month data of where we are on mechanical ventilation, really be able to separate the lung rest versus the lung recruitment portion of these studies, and the end of the live patient data that we see from ELSO. So this here is the same group. They did a low spontaneous breathing effort during ECMO in a porcine model of severe ARDS, and this was back in 2020. And they tested their near apneic study, which was again the 20 over 10 or the delta P of 10 plus 10, and a rate of 5, versus a pressure support ventilation of 10 over 10. Now back to the terminology, a pressure support of 10 over 10 is the same as a peak inspiratory pressure over 20 over 20. As far as the terminology in a controlled mode of ventilation, we talk about peak inspiratory pressure, but in pressure support ventilation, we talk about the pressure support dose. So this is a pressure support dose of 10 over a PEEP of 10, which gives you a peak inspiratory pressure of 20. Basically, the tidal volumes are similar in each group. The pressure support had increased ventilation in dorsal regions, and the lung injury markers were no different. So this is basically saying, and what they say in their studies, the respiratory rates in this were about mid-30s up as high as 70s. So a respiratory rate as high as 70 spontaneously didn't provide any more lung injury. And what are these lung injuries? So pressure and volume induced lung injury. You got your barotrauma or your volume trauma, and others attalec trauma. That's the opening, closing of alveoli. You got your oxygen toxicity, your biotrauma, which is again your release of inflammatory mediators from injury cells, your ergotrauma, which is energy expansion of dynamic high stress respiratory cycles, your myotrauma, your diaphragm muscle injury, and this is common with ECMO if you're keeping your patient paralyzed for a long period of time. And then what's fairly new is patient self-inflicted lung injury, and this is the patient's intense respiratory drive. So again, this goes against a previous study that allowed spontaneous effort up into the 70s. But most importantly is to keep your patient calm and keep their work breathing low. So first question is, what's your most important aspect to lung rest? Is it decrease peak inspiratory pressure, decrease your delta pressure, which is the difference between your PIP and your PEEP, decrease your respiratory rate, or do you just say turn it all down? Right, I got no answers, but that's okay. Oh, there we go. Now a couple of them are popping through. Any one of these are an acceptable answer. The most common one, obviously, is going to be decreasing your peak inspiratory pressure, which is also related to your delta pressure. But it's not uncommon to just say turn it all down. But then again, you have to make sure you're not analyzing the moment. You want to analyze the entire ECMO run. So if you're choosing just turn it all down on day one at ECMO, you may be providing lung de-recruitment far past what we want to do. So again, there's nothing set in stone with mechanical ventilation during ECMO, which is the most interesting part of this. And it's all a strategy, and the changes you make on day one really are going to affect week 2, week 3, or getting into the month of ECMO. So what does ELSO say? ELSO, as far as current recommendations, neonates, low FiO2, low peak inspiratory pressure, PIP 15 to 22, respiratory rate, moderate 12 to 20, and a moderate I time to maintain recruitment at 0.5. Pediatrics, they're looking at a little bit higher, a PEEP 10 to 15, a low respiratory rate, and a fairly high peak inspiratory pressure of 28 to 30. The thing with ELSO, they're looking at this as globally, right? So you think of a diaphragmatic hernia, you're not going to put them on a high peak inspiratory pressure. They have low lung volume to begin with. You don't want to cause high, you don't want to use high inspiratory pressures on these patients. But then they're also looking at the cardiac patient, the hypoplast. On these patients, you don't want to cause atelectasis. So you want to have a high peak inspiratory pressure. So these recommendations from ELSO are you have to remember they're global. So they're gonna be covering the basic patient, all of the patients, not a specific disease process. So this study, association of ventilator settings with mortality in pediatric patients treated with ECMO for respiratory failure, and this was published in ASAIO in 2022. And this was looking at ECMO runs from patients 29 days to 18 years. Most of these patients are VV. Most of these patients are ventilated with conventional mechanical ventilation with a mean airway pressure of 22. But if you go through 24 hours after ECMO initiation, the most common settings are 20 over 10 or a delta 10 over a PIPA 10, low rate, low FiO2, and ventilator settings independently associated with mortality are PEEP and FiO2. So a PEEP greater than 10 or a FiO2 less than 0.45. You do have to take the ELSO data with a grain of salt. Remember, ELSO data is 12 hours of ECMO. We record their ventilator settings. So if you think of a long run, you think of think of a short run, meconium aspiration syndrome. That's going to be a short run. I think of a long run congenital diaphragmatic hernia. That's going to be you're looking 3, 4, 5, 6 weeks. We had a couple CDH patients go for 100 days. So if you think of the 12-hour data manipulating mortality, that doesn't seem right when you're thinking about a patient a month from now. So take these papers for what the education they provide and the information they give you. But just remember, most of these papers report data from a 12-hour timeline, which would be really nice to know what settings they come off on, or what settings, or even the time that they start the re-recruitment, which would be very interesting. So types of modes of ventilator support during ECMO. So I don't have any bias towards any particular mode. Most important is knowing how that mode is going to interact with your patient, and obviously just knowing everything there is to know about that mode. So conventional mechanical ventilation modes, you have a pressure control mode, there's going to be pressure control. If you add pressure support, it's pressure SIV. If you're strictly just pressure support and no control of inspiratory time, you're going to be in pressure support mode. You have a airway pressure release ventilation. As far as volume modes, you have volume control ventilation. If you add pressure support, volume control, synchronized intermittent ventilation. The combined modes, pressure regulated volume control or PRVC, add pressure support, it's just a SIMV on top of that. And then not too common in the initial phases or even the middle phases of ECMO is high frequency oscillatory ventilation, high frequency jet ventilation, although sometimes these modes are used to push someone off ECMO. If there's one mode on this whole list that interests me the most, it is airway pressure release ventilation, which is APRV. This mode of ventilation, it holds a mean air pressure. It has releases, short releases, very quick releases. It's inverse ratio ventilation. But this mode of ventilation does interest me because it does have a lung protective side of it, but it also has a lung recruitment side of it. And I do understand there's a lot of studies that show this is detrimental to neonatal and pediatrics. But in the combination of ECMO utilizing sweep gas and a CO2 gas exchange, you don't need the releases as often as not on ECMO. So this in my mind would be a good mode for lung rest as well as lung recruitment. So next question is, what mode of ventilation do you use for rest settings? Do you use a pressure delivered mode? Do you use a volume delivered mode? Do you use a pressure regulated volume control, or do you use airway pressure release ventilation? And in neonatal pediatrics, pressure control modes of ventilation, so pressure control or pressure control SIMV or pressure support ventilation are going to be the most frequent modes of ventilation. So this article, Mechanical Ventilation in Children on VV ECMO and Respiratory Care, back in 2020. So they do mention no evidence-based guidelines or expert consensus for this patient population. A little over 200 subjects were included in this, looking at the first 7 days of ECMO. A majority of these patients were using pressure targeted mode, which is common in pediatrics. The most common non-traditional mode was APRV, coming in a little over 13%. No observations between clinical outcomes of peak inspiratory pressure, peak mean air pressure, or high mean air pressure targeted modes. But what's interesting here is ventilator FiO2 was significantly associated with mortality. For every 0.1 increase in FiO2, there was a 38 increase in odds of mortality. This sounds very significant. With VV ECMO, you just have to remember you still need the native output from the heart through the lungs back to the heart and to the systemic circulation. So it's going to still mix with poorly oxygenated blood from the lungs. And then again, VV ECMO is often limited by cannula size and ECMO flow. But again, you have to look back. The ELSO data is only the first day of ECMO. So we're not taking consideration what's going to happen in week 2, week 3, and again in 1 month. Going to different options of lung rest. So you have a complete lung rest. This is going to be typically CPAP or low-level pressure control, or possibly extubation. And extubation is primarily used in older pediatrics or adults, more often adults than pediatrics. But if we just focus on the neonatal and pediatric group, these pediatrics are the ones that are going towards lung transplant. They're probably most likely trached. And their combination of their native inspiratory tidal volumes and ECMO are going to be able to have them do trach collar sprints or potentially be on trach collar all the time, primarily helping them with rehab and going towards lung transplant. And then you have the moderate lung rest strategy. This is moderate levels of PIP PIP and peak end expiratory pressure strategy with low respiratory rates, long inspiratory times, and this is what's going to be your maintenance to recruitment. In this phase, a true understanding of respiratory mechanics and patient and ventilator interaction are extremely important here. In this mode of ventilation, it's very easy to cross over into that lung injury category. Lung recruitment strategy. So sustained inflation, progressive PEEP, tidal recruitment, airway pressure release ventilation. This is one that uses excessively long inspiratory times, increases min-air pressure, uses staircase PEEP recruitment, looking at compliance and judging which ventilator settings are going to be most appropriate. But again, if you recruit too early, you're going to cause more lung disease than you'd like to. So what mechanical ventilation strategy do you use on ECMO? Do you use a complete lung rest, a moderate lung rest, or a recruitment strategy? And this one here, it's most of the ECMO centers that I talk to, you do use a complete lung rest strategy. The one kind of caveat here is, if I split this question into a VA or VV, VA, you get a little more bypass, cardiopulmonary bypass, and you're probably going to be choosing a complete lung rest strategy. But if you are more of a VV center, you're probably using a moderate lung rest strategy, because when you go on VV ECMO, you really have to be cognizant of decreasing your main air pressure, because you don't necessarily want to de-recruit the lung as you go on VV, because it's less bypass, or actually no bypass, because you still have to shunt all that blood to the lung. So in order to maintain a appropriate PaO2, you need to have some type of lung recruitment. And lastly here, it's really hard to give any type of ECMO lecture without talking about anticoagulation. Anticoagulation pretty much affects everything in regards to ECMO. So this study here, heparin impairs angiogenic signaling and compensatory lung growth after pneumonectomy. This was published in 2018. This was published by Mark Puder, which is a surgeon at Boston Children's Hospital. And they used 8 to 10 week old male mice, underwent a left pneumonectomy, followed by daily injections of saline or VEGF, which is vascular endothelial growth factor. Lung volume measurements and polymorphic analysis were performed on postoperative day 4 and 10, and lung volumes on day 4 were higher in the VEGF treated mice. On analysis, VEGF increased the parenchymal volume, alveolar volume, and alveolar number. What's interesting is they used either heparin or bivalirudin in these mice, and lungs of heparinized mice displayed decreased VEGF compared to the control group. The use of bivalirudin, again, which is an alternative anticoagulant that does not interact with VEGF, preserved lung growth and pulmonary mechanics. So my takeaway from reading this is there's a lot of ECMO centers, and it seems like every ECMO center that I talk to is going towards bivalirudin, especially the centers that are treating diaphragmatic hernia. And if you think about a diaphragmatic hernia patient, these are the one patients that really need lung growth. And this is one of the first studies that shows bivalirudin doesn't affect lung growth, it preserves lung growth, compared to heparin that inhibits lung growth. So just something to think about that I think is very important towards mechanical ventilation with ECMO. So that's all I got. If you have any questions, I can go into the Q&A to see. So hey Dave, what does your center like to dial in for eye time once on ECMO? So again, we look at the flow waveform, on the ventilator. We do like to extend the time on zero flow, so we do use a long inspiratory time. So which is, you know, typically if you think of a neonate, 0.3 to 0.4 inspiratory time, we usually double it and go to 0.6, or a pediatric, you know, 0.5 to 0.8, we'll double that, and even sometimes go as far as 2 seconds. And APRV is becoming more widespread. The correct situation with ECMO, in my mind, I almost think all the ECMO patients could benefit from APRV. Again, going back to those studies that say APRV is detrimental, but all these studies are not on ECMO. So again, I think APRV is a very good mode of ventilation, and could provide lung rest and lung recruitment all at the same time with the same mode. All right, no other questions. Thank you for having me, and I hope you learned something today.